So palliative care, it's both oncology and non-oncology cases holistically. I'll focus on oncology care, however my internal medicine background does cover the other cases such as diabetics with end organ diseases. If you look at the definition of palliative care and compare it to what we have here, the status in a nutshell is our service is inadequate. The demand is such that our services cannot keep up with it. We, through the oncology unit itself, we are struggling. We are struggling to meet palliative care needs. In fact, if I had to put it bluntly, it's inefficient, and not because of a single factor. It's because of multiple factors. So we have these services. They're very rudimentary at the moment, and there is a lot of space for improvement. Palliative care in itself, we were asked, do we have a unit? We said no. But in fact, most of the treatment that we give, most of the cases that we see, we've basically been doing palliative care informally over the past years. It's just now that things are developing that we realize that most of our treatment is palliative rather than curative. If you look at the statistics, perhaps it's almost close to or more than 50% of the cases receiving palliative care, because people keep getting NCDs with end organ damage, cancers now, at advanced stages we find them, and then everything is palliative. So a couple of years ago, the Fiji Ministry of Health looked at, trying to streamline our aims, our services, and tidy them up, and we came up with the National Cancer Control Plan. In draft form, however, it did look at improving palliative care as a whole, and it does have 4 elements, one of which is get a unit up and running, and so we have that now. Although it's one nurse, it is a step up from before. And we hope that over the years, as things go, that one nurse will then eventuate into a whole unit. That's how everything else started, just by one champion and building up a unit. Number 2 is, policies and legislation. We never had that before, or it was there just needing review, and we've managed to get people in to train us more on the treatment aspect. We've had teams coming in from Christchurch through Nurse Maud Hospital, where some of us have had contact, and they've managed to take our nurse for training. So we've got a unit, albeit one nurse, but we've got plans in place. We've had some training, and then yes, it may be small steps, but it is a step up compared to the past. It's the powers that be to actually step up and understand, or to acknowledge that we are not providing enough palliative, we are not concentrating much on palliative services. We need a boost in that. So legislation, the same interest that's been given to other units, cardiology, NCDs, we need the same thing in palliative care. Our patients are struggling, and so are we. So we need those in power to acknowledge that this is a problem and invest in it. And through that, we'd have at least some dedication into improving the resources. Then we could get staff improvement, human resources, the structure itself, the infrastructure for a palliative care unit. But it needs to start, from the top. We do have our plans, but without the commitment from governments, these plans are just plans. Well, firstly, I'm a clinician, and for me personally, coming over to talk about palliative care, my oncology experience, I thought Fiji was in isolation. However, the feedback I got from the audience during and after the talk was that No, everyone else is struggling like us. And more importantly was these directors, seemed willing to take it up to their heads of health and say, yes, this is something that it's not we should invest in, we must invest in, because it's increasing over the past years. It's not a new sickness that's come up, it's just the same things that we're struggling with over the years. So I was quite, I was taken aback with the response that I had, and it looked positive. When I saw the other Pacific countries were essentially the same as Fiji's level.